Good afternoon, all. We'll be taking the second plenary session, which is on diabetes technology. And to chair this session, is Professor Olamoyegun, and to co-chair is Patrick Nwayaun. So please, can you come up?
So good evening, everyone. We've gotten to the last presentation for today, and the topic of our presentation, as we've been told, is diabetes technology. And our guest speaker, who is going to present virtually, is Dr. Gedolin Ayanati. She's an endocrinologist and internal medicine physician. She's going to speak to us from the US. I guess he's around. Oh, okay. So I'll call, Dr. Ede to read a citation.
Good afternoon, ladies and gentlemen. It is my honor and privilege to introduce the speaker for the second plenary session. Dr. Ayanat Gwendolyn Jack is an assistant professor of clinical medicine at Weill Cornell Medicine's Division of Endocrinology, Diabetes and Metabolism. She received her Bachelor of Arts degree from New York University. She earned her Master's of Public Health from Columbia University, Millman School of Public Health. She earned her medical doctorate at Sidney Kimmel Medical College in Philadelphia. She completed her internship and internal medicine residency at Johns Hopkins Bayview in Baltimore. She completed her fellowship in endocrinology, diabetes and metabolism at Beth Israel Deaconess Medical Center, Joslin Diabetes Center at Harvard. She's board certified in internal medicine and endocrinology, diabetes and metabolism. She's the lead of the ambulatory diabetes program at Weill Cornell Medicine Division of Endocrinology, Diabetes and Metabolism, where she developed a clinical workflow for optimizing the visualization of glucose data and connective diabetes technology devices. She currently is an advisor of the American Diabetes Association ADA Diabetes Technology Interest Group. She has been an invited speaker to several national presentations focused on integrating diabetes technology using a team-based approach to optimize clinical workflow, integrating diabetes technology in primary care clinical settings, and diabetes device burnout. She has served as co-author on several publications, most recently as first author of the May 2025 Journal for Clinical Endocrinology publication. She is currently the principal investigation of an IRB-approved study focused on exploring the differences in the utilization of diabetes technology at ambulatory sites at Weill Cornell. She has received several awards for excellence in mentorship, excellence in medical education, and leadership in community engagement. Dr. Jack is passionate about diabetes technology, community engagement, medical education, and enhancing the learner, patient, clinician, community partnership. Ladies and gentlemen, join me in welcoming Dr. Gwendolyn Jack.
Perfect. Thank you so much. Thank you for the introduction. So I'll just start off here today discussing diabetes technology. I serve as a lead of the ambulatory diabetes program here at Weill Cornell Medicine. So starting off with, I have no financial disclosures. I do want to describe some of the continuous glucose monitors today highlight some of the approved continuous glucose monitors, as well as provide an overview of current automated insulin delivery systems. So first, starting off with the basics of continuous glucose monitors. So we start off first with the transmitter and then also the glucose sensor. So the glucose sensor actually senses glucose that is within the interstitial fluid. So that's the fluid in between the cells. And that is different from where the finger stick machine, when the patient pricks their finger, that actually is within the blood vessels, the capillary blood vessels within under the skin. So that makes sense later on because that's why we have sometimes different readings between what we see in the finger stick versus what we see in the glucose sensor. And so once this needle from underneath the skin, we have this transmitter here, then sends the information over to a receiver. So it can be a separate receiver, or the receiver can be a phone, a smartphone. And there's significant value in the use of continuous glucose monitors for diabetes management. What we know is that the hemoglobin A1C is a very important parameter, but it is not the only parameter that we should look at. There are many facets and many phases of an A1C. So I use this diagram on the left here to show different individuals who have an A1C
Sorry,
of
Dr.
7%.
Your slide is not moving. Your slide is
Yeah, the slides are not moving. The slides are not moving, you said?
No.
Okay. So what I was referring to here were the different phases of the hemoglobin A1C. So what we can see here is that the A1C of these individuals all have an A1C of 7%. However, if we were to look at the continuous glucose monitor data, what we would be able to see is that 20% of the time, this individual is actually having blood sugars that are low, or hypoglycemia, and then 40% of the time, this individual in A is actually having hyperglycemia. And only about 40% of the time is this individual within this target range of 70 to 180 milligrams per deciliter. And then when we look at individual number B, we can see a little bit better. So 70% of the time, this individual is within the goal range. However, there is still some instances of this individual experiencing low blood sugar, and about a quarter of this time, this individual is actually experiencing hyperglycemia. And then when we look at C, 100% of the time, this individual is actually experiencing blood sugars within the goal range. So the limitation of the A1C, the blood test, is that we're unable to actually identify any day-to-day variations and really see any patterns of hyperglycemia or hypoglycemia. That's where the continuous glucose monitor can provide that additional information to be able to actually identify when an individual is experiencing hyperglycemia or hypoglycemia. And then in terms of the rest of the limitations of the finger prick or the self-monitoring blood glucose, what we can see here in the orange these are the finger pricks. So if we were to rely only on these 4 finger pricks, it would seem as if the blood sugar is within the target range. However, what we're missing from this continuous glucose monitor data, it actually shows us that the individual is experiencing hypoglycemia or low blood sugar that is not being captured by the finger stick. And this individual is also experiencing hyperglycemia that is not being captured by the finger sticks. So again, the finger sticks are important, but again, there are limitations to the finger stick where it only captures the glucose at a moment in time, and it also depends on the frequency of finger sticks. So someone who's checking their finger stick once a day, it's hard to really assess if there are any patterns in hyperglycemia or hypoglycemia. And that's where the continuous glucose monitor really plays an important role. What we also know is that there are so many benefits of continuous glucose monitoring systems in individuals who have diabetes based on numerous studies at this point. Continuous glucose monitors, or CGMs, can help to actually identify patterns. So if an individual is having hyperglycemia after breakfast or hypoglycemia overnight, we can identify that and adjust our treatment plan accordingly. It also helps to reduce finger sticks, which can be quite painful for certain individuals. And as a result of it being painful, they may be less likely to actually perform the finger stick. It also allows the individual to share data with the medical team, and the medical team may actually not be local. That medical team might be outside of the local setting of that individual. It also allows individuals to actually share data with their family members or loved ones who can pick up or get alerts if the individual is experiencing any low blood sugar episodes that require intervention. Again, then related to that includes that most of these continuous glucose monitors now also have the benefits of alarms and alerts. So it can alert an individual who is having or going to have a low blood sugar episode before the individual actually has a low blood sugar episode. So that way there can be an intervention before the individual experiences a hypoglycemic event. Also can have alerts if the blood sugar is very, very high, and that can help in terms of promoting intervention before the patient has to actually go into the hospital for diabetic ketoacidosis. And then it has additional benefits of downloadable reports, which I will show an example of later on. And then studies have also shown that having continuous glucose monitors can lower the risk of having hypoglycemia or severe low blood sugar episodes. It can also reduce the glucose variability, so indicating that there's less likelihood of having such high highs and low lows, and keeping the blood sugar a bit more stable. And the studies have also shown a reduction in the A1C up to 1.5%. So overall, using continuous glucose monitors can really improve glycemic management for individuals who have diabetes. I also want to make a point here, the difference between a sensor glucose from the continuous glucose monitor versus blood glucose from the finger stick. And this is a great diagram that really shows what the difference is. Like I mentioned before, the sensor glucose is collected from the interstitial fluid, which is in between the cells, as opposed to the blood glucose, which is actually collected from the small blood vessels in the finger. And so what we can see here is that when the blood sugar is stable, the sensor readings and the blood glucose readings are exactly similar. When the blood glucose level is actually trending up, then the sensor readings may be actually lower than the blood glucose levels. So the sensor readings are the blue cards in the train, and the blood glucose are the red cards in the train. And when the glucose is trending down, we can see that you see the red card quicker, and so therefore the sensor readings might actually be a little bit higher, and then the blood glucose readings. Okay? So this is important to know, because what you'll see is that sometimes people may have disruptions in the system because they see two different numbers, and what we say is that having the two different numbers is actually expected, because it's checking the glucose at two different places. One, the finger stick is checking at the blood capillary, and then the sensor glucose is actually from the interstitial fluid. So there is an expectation that both numbers will most likely not be the same, but if someone has just eaten anything or just exercised, again, that might lead to the blood sugar rising quite up and making more variation between the blood glucose reading versus the sensor glucose reading. So that's a very important tip that we give to our patients. And then what are the different options that we have available? So there is a real-time continuous glucose monitor. So this really measures and displays the glucose levels continuously. So meaning that every 5 minutes, the continuous glucose monitor is actually registering the blood sugar, and the individual can see that data in real time. This is different from the intermittently scanned CGM, or known as a flash CGM. This actually measures the glucose levels continuously, but actually requires for the individual to scan in order to see that data and store the values. So for example, for the Freestyle Libre, the initial one, and the Freestyle Libre 2, you actually have to scan every 8 hours in order to obtain data. So that's just a picture on the right there that shows the individual who's scanning the data in order to be able to obtain the data. And then there are professional continuous glucose monitors. We use this in the healthcare setting sometimes in the office, where we have continuous glucose monitors that we provide to patients. We give it for a finite period of time, so usually 10 to 14 days. The patient wears it, comes back to the office, and we're able to download that data and prescribe any medications or adjust the treatment plans based on the data that we receive. Again, that's not a long-term solution, but it allows for us to be able to at least make treatment plans because we would be able to have the glucose data at the time of the visit. And I also wanted to highlight here that there are different systems. And of course, this can vary based on location. So in Europe versus the US and versus in Nigeria, what is available might actually differ. I will highlight here what is readily available now in the United States and may be applicable to other locations as well. So you might hear of the Dexcom G6 and G7. The main thing to know here is that it can start off very early. So this can start off being used in pediatric patients at least the age of 2. And the duration of wear is 10 days. It does not require any calibration with the finger stick, so it's less burdensome for the patient, and it uses Bluetooth. So there has to be Bluetooth capability for the patient. It is compatible with some of the insulin pumps, which I'll talk about much later. Okay. So the Dexcom G7 is the newest version of the G6. And then the Libre systems. So there are different Libre systems. There's an initial or the original Libre system. There's a Libre 2. There's a 2 Plus, Libre 3, and the 3 Plus. And what I really want to highlight here is it's important to pay attention to the age indication. So the 2 and 3 Plus all have the indication above the age of 2, whereas the original Libre 1 and also Libre 2 and 3, the age of indication is age 4. You'll also notice the differences in the sensor duration, so how long the patient can actually wear the device for. The newer versions of the Libre 2, so 2, 3, and 2 Plus and 3 Plus do not require any calibration, but it's also important to know that Bluetooth capacity is needed as well. Some of them, like the 2 Plus and the 3 Plus, are integrated or can interface with an insulin pump, whereas the 2 and the 3 do not have the capacity at this current moment. And then these are additional continuous glucose monitors that are used in a couple of pumps. So there's a Medtronic, Guardian, and the Simplera. The duration of wear here is about 7 days. That is actually different from the Eversense 365. So the Eversense 365 is an implantable continuous glucose monitor that is implanted under the skin and is actually approved to be worn for the entire 12 months or the entire year. It does require calibration, and it is not compatible with any insulin pumps. I'm going to take a moment here to also kind of go over the ambulatory glucose report. So when we tell patients or counsel patients to get started on a continuous glucose monitor, I mentioned one of the benefits is being able to actually see the data. So here, this is a great approach that I use is assessing the sufficiency of the data. So ensuring that we have enough data, so that includes that the patient has worn this continuous glucose monitor more than 70% of the time. And then we also assess whether or not there is high variability in the blood sugars. Again, thinking about whether the patient is experiencing high highs and low lows. So we have our goal of the continuous glucose monitor glycemic variability being less than 36%. So 49%, 49.5% would suggest that there's a lot of glucose variability. Okay, so it looks like a roller coaster. We also want to identify any hypoglycemia or time below range, and then assess sort of the time within range. Typically for an adult, non-pregnant individual, we want that target range of 70 to 80 milligrams per deciliter to occur at least 70% of the time. And then we also want to assess for any patterns of hyperglycemia or time above range. And then assess for, again, patterns of glucose variability. So when we look at the glucose profiles, this is why the information is so key, is that we can see here in this particular individual that this individual is experiencing hyperglycemia, but also having hypoglycemia indicated by the red drops. So hyperglycemia and then drops, right? And this is happening randomly throughout the day. So this can really inform our treatment plan, because it's possible that maybe the insulin dose might be too high in some settings, or maybe the person is actually exercising and we may need to reduce insulin prior to exercise. So this is a great resource that we use here. It allows for you to be able to see the different options of devices, not only in terms of continuous glucose monitors, but also finger stick machines and insulin pumps as well, and get some information about each device and which is appropriate for that particular patient. And then I'm going to switch over to insulin pumps now. So the basics of insulin pumps is that we have a device here that is connected usually to a tube. There is a tubeless option called AMIPOD. The rest actually have a tubing through which the insulin is actually delivered through the insertion site injected actually into the fatty tissue below the skin. And then it's dispersed out so that the individual gets the insulin throughout the body, and that helps to lower the blood sugar. So two main options here are the open loop insulin pump. That refers when the individual has a continuous glucose monitor and the insulin pump. However, there is no communication between the insulin pump and the continuous glucose monitor. So that means that the patient actually has to input the data into the insulin pump for the insulin to be delivered for the boluses. That is different from a closed loop or automated insulin delivery system, whereby there is a continuous glucose monitor, there is an insulin pump, and there is a Bluetooth-enabled device. This really allows for communication between the continuous glucose monitor, the Bluetooth-enabled device, which can be a phone or a smartwatch, and the insulin pump. And this is also helpful because it can have guardrails. So, for example, if the continuous glucose monitor indicates that the blood sugar is dropping and the individual is going to have an impending hypoglycemic event, the insulin pump can actually shut off the delivery of basal insulin so that the patient does not have a hypoglycemic event. Similarly, if the blood sugar is very high, as being registered on the continuous glucose monitor, the pump can actually give additional insulin to try to lower the blood sugar. So right now, there are several insulin delivery systems, closed loop, that are on the market. Again, this can vary based on geographic location. The ones here in the US are the MiniMed 780G, the Insulin Omnipod 5. Again, that is only one that is tubeless, meaning that there is no tube that is attached to the body. It is only the pod, the Omnipod pod itself, that is attached to the body, and the continuous glucose monitor. There's also the iLet bionic pancreas pump, the Tandem Control IQ, and a newer version called the Tandem Mobi, which is very, very small, but again, it also has tubing. And then the newest version that we have on the market now, that was just released, was the MedTech Twist. So I show this here to compare the different systems and the ages of indication and whether or not a patient may benefit from it, depending on the unique characteristics of the patient. So, for example, the age indication, some of them you'll see there at least the age of 6, and others it's at least age of 2 or 7. And then most of them actually have a bolus calculator. The only one that does not is actually the bionic pancreas pump. And then also thinking about the insulin volume. So how much insulin can be held within the pump itself? It can range from 180 units in the iLet bionic pancreas pump up to 300 units in multiple pumps that we can see on the screen. And this is important because there are some individuals who require very high doses of insulin. And so if it's only 100 units that's in the actual cartridge, it might run out quite quickly for that individual. Also, the different pumps may have different target settings. And so some of them you may be able to set the target from 110 to 120 or 100 to 120. It all depends on the insulin pump. I will say the newest pump called the MedTech Twist, you can actually set the target as low as 87 milligrams per deciliter. So again, the main crux here is that in order to really get the most benefit from the insulin pumps, it's really about finding out what would be beneficial for that particular patient. And then some of them also have the additional feature of having exercise activity or sleep activity. where the goal or the target blood sugar is actually set lower or higher depending on whether or not the individual is exercising or going to bed and sleeping. And this is another resource that is really helpful. It helps to sort of compare the different insulin pumps, the characteristics and the benefits of each and any unique features that they may have. And then when we consider pumps, I think about the A, B, C, D, E, F, G, and H. So how adjustable are the settings? For some people, having too many adjustable settings can be very overwhelming. And for others, they really like to be able to fine-tune and adjust their settings accordingly. And also the alerts and alarms. So sometimes, in a pump that has too many alarms, that can be, again, overwhelming for the patient, and they may altogether no longer want to use the pump because they're getting woken up at night or being interrupted in meetings for erroneous alerts and alarms. Also thinking about the bolus calculator and meal announcement. So like I mentioned before, some of the pumps, there's one pump where you can only announce a meal. You don't necessarily need to input how many carbs that are in that particular meal, which for some individuals can be a challenge calculating how much carbs are in a particular meal. C for the CGM integration. So again, most of these pumps now actually have a CGM that's integrated. There are some people who insurance may cover a freestyle versus a Dexcom, and so sort of taking that into consideration. And then D for device size. So there are some pumps that are very small, other pumps that are larger, and so depending on the patient preference, someone may actually prefer one that is a smaller size. And then also thinking about ease of use of the actual device. So one individual may actually prefer another pump because it's much easier to use. You don't need to change as many settings, and another actually may prefer something that requires a bit more hands-on. And then again, the feel of the pump. It's always important for the patient to actually feel the pump and hold the pump and sort of move with the pump before actually getting the pump placed on. And then I use G for game changers. So these are some of the special features. So like I mentioned before, there are some pumps that have the exercise or the sleep activity profile, which can allow for further modifications of the pump settings. And then also, again, how much insulin that the pump actually holds, right? The volume of insulin that it can hold, whether it's 180 units versus 300 units. So I'm going to end off here with this article that was actually published recently, and there might be some of the authors here as part of this conference that really actually looked at the automated insulin delivery systems in Nigeria. Of course, I've been discussing some of the CGMs and the insulin pumps that are in the North America, but I want to make sure that I'm also paying attention to kind of what are some of the concerns more locally. So this review article did a wonderful job of really displaying some of the advancements in diabetes technology, but also some of the challenges and opportunities for integrating more diabetes technology in the future. So they identified several themes, again highlighting the fact that insulin pumps or AID systems, more specifically, were able to improve A1C by up to 1.5% and also reduce diabetes-related complications. And this is based on data from multiple studies. Also notable was that they mentioned, based on the articles published, that the first adoption of CGMs and pumps in Nigeria were actually observed post-2018. And looking at the rest of the literature, there was a significant spike in the publications surrounding diabetes technology since 2018. However, they also highlight that the uptake of continuous glucose monitors and insulin pumps is still quite low and is really has been confined to private settings in urban areas. And it seems like the freestyle systems are more often used than the Dexcom systems and insulin pumps altogether. They also highlight the fact that insulin costs have increased significantly over the years, from 4,000 to 19,000 naira. So, if insulin is costly and insulin pumps are costly, you can understand that that might also contribute to why it is not utilized as often as it could be. Also highlighting the fact that there is a technology and infrastructure system that could be better developed, and highlighting perhaps other ways that we can make sure that this technology is available in different settings, not only in the urban areas. And they also highlighted that the Alexa glucometer factory was actually launched only a couple of years ago, back in 2023. And then also highlighting the fact that there still is some trust that needs to be established regarding the use of technology, and then sort of mixing that in with some of the experiences with alarm fatigue that I mentioned before, and how bulky or large the actual insulin pump is, and how it can actually interfere with daily activity. And then overall, really taking a look at the policies, and having policies that support the expansion of diabetes technology. And so they, again, highlighted the barriers, but also did a nice job highlighting some of the solutions that can be explored. So again, improving the infrastructure, especially in rural, then encouraging local manufacturing, just because of the high cost of CGM and biomedical startups, and reducing the price of the import duties as well. And then to sort of combat some of the challenges in terms of having a buy-in about diabetes technology, and instead of the full reliance on traditional medicine, really optimizing education of the populating community leaders as well. And then also, in terms of the distress of the new technology, the best way to combat distress is really by having that hands-on training, being able to see the device and demystify the fact that this is, this foreign object, and that really recognizing that there's such value in integrating this technology. And in response to sort of the lack of or the inadequate framework, a regulatory framework of these medical devices, they recommended having specific policies for the use of diabetes technology. These policies would be clear and transparent, but it would also make sure that patient data was protected. And then in response to the lack of trained healthcare professionals in diabetes technology, read an article that there are less than 200 endocrinologists in Nigeria. So I think, it's really important that they highlighted here that there has to be more efforts integrating some of this technology into medical education and continuous professional development programs. And so I will end off here in conclusion that CGMs are important tools in the management of diabetes. Automated insulin delivery systems, or AIDs, and CGMs have different features and really need to be tailored to the person with diabetes. And even though there are barriers and there are challenges, with challenges also come opportunities. And so there are also opportunities to increase the utilization of diabetes technology across the nation. This is just a picture of the first insulin pump from the 1970s, which you can see here is a large, very bulky insulin pump that was pretty much worn as a backpack. And this is quite different from the much smaller devices that are now available. All right. That's it. Any questions?
Thank you very much, Dr. Gbedolik Jack, for this beautiful presentation. Let's appreciate her with another round of applause. Thank you. So we want to give room for questions, comments, and contributions. Anybody? Questions? Maybe one or two? Anyone? Okay. So, okay.
And I'm having a hard time hearing. So if the question is asked, can someone also put it in the chat for me so I can also respond.
Okay. Thank you very much for that brilliant presentation. My question is this: concerning the insulin pump, I know that they said they have to have some sort of training before using the insulin pump. So how long does that take? How long does that training take so that the individual will be used to it? I just had one sad story now where I was told that someone had an insulin pump put on, but then the thing wasn't regulating well, so it kept on discharging and the patient died. So how long does it take to get a training to be able to use the pump effectively? Thank you.
All right, great question. So the question of how long does it take to actually train a patient before using it, that is fantastic. So first, what we really encourage is an assessment, right? So meaning, what is the patient's understanding of the insulin pump to begin with? What is their level of comfort with the diabetes technology? Are there areas that we need to work on first before even transitioning the patient over to the insulin pump? So does the patient already feel comfortable with the basal insulin? Does the patient feel comfortable with carb counting, meaning that they're able to recognize how many carbs are in a particular meal and be able to input that information into the actual device, right? Does the patient also realize the connection between physical activity and also blood sugar, meaning that for the most part, people who exercise right after exercise, and they have hypoglycemia, not even just immediate, but also several hours later. So understanding sort of the overall background first, and then once we are able to transition them over to a pump, then it's reinforcing that, right? So we recommend following closely with the patient about a week or 2 weeks after actually transitioning them to a pump, because they'll start having they may start noticing things by using the device, and you want to be available to actually answer those questions that they come through.
Okay. Thank you very much for your answer. We appreciate your presentation. I want to appreciate you for the time you have given to deliver this presentation. Just to appreciate you, we want to give you this plaque in recognition of your time, and to get it on your behalf, it's all on Professor Samuel, and then that will be given by our president, Professor Oloko. Be sure that we'll get it across to you in the US.
Thank you so much.
So, the Endocrine and Metabolism Society of Nigeria, EMSON, presents this plaque to Dr. Mendolin Anyanati in appreciation of your role as guest speaker at the 46th Annual General Meeting and Scientific Conference, Lagos 2025. Congratulations.
Thank you. Thank you so much for the invitation. This was such a pleasure. Thank you.
Thank you very much. I think we have come to the end of the presentation today. Dr. Lokpade, information?